Hello, good evening. How are you doing? Can you hear me? Hello, can you hear me? Hello, test my microphone. Hello, can you hear me? Hello, can you hear me? Let me see what can I chat? Can you hear me? I believe can hear me. I want us to get started. Okay. Can you hear me? I'm not be sure. I'm not sure. Let me join with my phone to see if it's audible. So, hello. Oh, great. So let's get started. Father, we thank you today for the privilege and opportunity we have to study. We pray that you grant us understanding in everything we review, Lord. In Jesus' name we have prayed. Amen. So we are going to be continuing from where we stopped last time. We're going to be stopped continuing from slide 33, which is we're starting from slide 33. I'm going to share my screen and hopefully we'll have to, yes, let me see. Good. I'm surprised. Let's see. To slide 33. So we stopped at slide 33. Um, let's see. Let me show that. Can you see my screen clearly? Let's see.
Yes. Good evening.
Good evening. Welcome. So the honest truth to tell you the honest truth. Um, blood bank is huge, and for us to cover blood bank completely, we have to be very patient. We're going to cover it. And my goal is that I want you to do very well in the right exam in blood bank. If you have time to do in another ECP, that would be great. At least blood bank and then blood bank cytology, surgical pathology, GI. So I'm trying to see how we can cover as much as that. But the truth be told, blood bank is huge. If we can cover it in 2 months, wow, then we are very, very good. I mean, it's something that people study a whole year after residency. So if you want to have a thorough understanding, you have to be very patient. They say slow and steady wins the race. Sometimes if we want to be too fast, we may not be able to get all the benefits that we are supposed to get. So now we are going to be continuing with let me see. Good. We stopped last time at donor infectious disease screening and was actually tested in the United States. Um, so we're going to look at it at hepatitis. If after you've collected blood from the donor, what is it you want to test for? You want to test for hepatitis B virus, hepatitis C virus, HIV virus, ATLV1 virus, HLV1 and 2, Trypanosoma cruzi, and Babesia. We're going to break it down again and again and again. There's what we call NAT. NAT stands for nucleic acid test. Nucleic acid test is looking for the DNA chromosomal, let me say DNA or nucleic acid material like RNA of the virus. It's a very sensitive test. It has improved detection. Before now we used to have what we call window period. By the way, I'm on call, so I may be called off to do something or something, but I'll quickly come back. There's what we call window period. In the window period, sometimes when someone gets infected with a viral infection, it does not appear immediately. It takes time to appear for that viral infection to appear. So that's called window period. A lot of times people have donated blood and they're HIV positive. But that time we're doing all these ELISA tests. ELISA actually takes like 56 days to become positive. So that means somebody can donate blood, can get HIV, and within that 56 days may not show up in the test and donate this blood that contains these organisms actively multiplying to this patient. Because when we do the HIV test, it will be negative, and then we don't see a patient developing HIV after being transfused with HIV infected blood that was not picked up by our test. So that's a problem. So so that's why people started to try to improve. People started trying to improve HIV testing. Before now, even in the 1980s, testing for HIV was was not even direct. When HIV first came out, they had to start doing hepatitis B core antibody, anti-hepatitis B core antibody for some people, and CD4 to CD4 CD8 count. So if the CD4 is falling and CD8 is rising, they would think that the person has HIV, and then they could even direct HIV test. Then if the person is positive for hepatitis B core antibody, then they begin to think this person has a high risk behavior for undergoing hepatitis and maybe at risk of HIV. So all these things are things that come into testing. So, but with second generation, then came the second generation HIV testing. I think maybe that's the ELISA staining, ELISA. Then came third generation HIV testing, and that one they have to use P24 and all that. We're going to go and get into all that. Then we have the fourth generation HIV testing. Now we use nucleic acid test. Nucleic acid test has shrunken the window period from the 56 or 55 days where we were with ELISA down to 10 to 11 days. So if somebody actually has HIV, the person can be detected, the virus can be detected within 10 to 11 days. And that's very good. That has significantly shortened the amount of people that can get all these viral diseases, even though they are screened negative in the test. So, what are the tests you want to use nucleic acid testing for? On hepatitis B virus, it can be used for RNA, it can be used for hepatitis C virus, it can be used for HIV, it can be used for um, WNV. WNV is what's WNV again? West Nile virus or thereabouts. So it's a what is virus that causes encephalitis or thereabout. West Nile WNV. Let me be sure that correct. WNV virus. It should be West Nile virus. So Then we have transmitted by by mosquito is the arbovirus. Then we have so this test syphilis still uses serology testing. Serology means use of antibodies. Syphilis uses serology. West Nile virus uses NAT also as well. Now, so these are the tests. You have to memorize these tests. You do hepatitis B virus testing for these patients. You do hepatitis C virus testing. You do HIV testing, HBV, HCV, HIV, so many H's and HTLV1 and 2 antibodies. This is serology testing, sorry. Is West Nile virus is serology. The ones that are serology are West Nile virus is is so the ones that are NAT are or the HBV, HCV, HIV, then HCV1 and 2 antibodies, serology, syphilis antibodies, and all the serology testing. Then WNV is also NAT. Okay. And then Trypanosoma cruzi, if someone is from Central America, it's done at least once. You do it at least once. The first time the person is going to donate, you do Trypanosoma cruzi. Just like somebody from Africa may want to do Trypanosoma brucei for sleeping sickness, but that's not a problem for us. So, but cruzi is a big problem because it's megacolon, megaesophagus, cardiac problems. So, Babesia, people that are from Babesia endemic area, you may want to test for Babesia. And mind the Babesia is also, you can use anything. I think there's an NET test for Babesia. I think we'll look at it to see that. So these are the tests you want to do in people that have donated blood. Okay, so malaria is not done. You don't do malaria testing for them. You don't do CJD, Jacob disease or thereabout. You understand? And then because of all this testing, we have noticed that the HIV transmission in the United States has dropped significantly to 1 to 2 million or even less, 1 in 2 million or less. HCV is still a little bit high, 1 in 800,000 to 1 million, because I think, but whatever, HCV too, before when we were using serology or something for HCV, the time was like 70 something days was when it took like 70 something days for a test to be positive during the window period. But with the NAT testing now, the RNA testing now, it has significantly um, cut it down. So the donor must test negative for all these things, and confirmatory test must be done before the thing is labeled for transfusion. If any of these tests, even one, is reactive, the donor will be notified and the blood test will be discarded. This is called multi-layer testing, and it's not, it has made the infections exceedingly very rare right now in the United States. Remember, we talked about the DHQ last time, the Fed DQ. I mean, the questionnaire. We talked about the questionnaire system last time, where people use questionnaires to make sure that they pick up people who are at risk and all that. So DHQ, delayed, I think healthcare questionnaire also. So we talked about that last time also. So having said that, there are some things people want to talk about. There's something called the Zika virus as well. Zika virus, when you mention West Nile virus, there was a time that Zika virus came out, and it became a problem in the United States. They say it was causing congenital problems for children. By 2025, the FDA removed um, I think recently, I can't remember exactly, but FDA has removed Zika virus. Zika virus is no longer being tested for, but West Nile virus is still being tested. And so the Zika virus is going to be dependent on any new emerging thing that has come up by the FDA. So is that one is subject to regulation or thereabout. So let's go to the next slide. Now we look at HIV and why NET matters, the window period. I already alluded to some of these. The first thing we have to see is that, like we said, antibody assays require time for the immune system to respond. People don't start making antibodies on the day one they have HIV. They have to wait for a long time. And remember, we talked about how they started from ELISA. ELISA was several days, but then they now came to the third generation third generation anti-HIV anti-HIV 1 and 2. The third generation anti-HIV 1 and 2 antibodies were able to, detect diseases within 22 days window. 22 days window. That means within 3 weeks, somebody will test positive. The window period was cut down to 22 days in terms of detection. Then came a very big significant breakthrough called the HIV P24 antigen. It's kind of it's a protein found in the viral capsid of HIV, and it usually appears in the blood even before the antibodies appears. So what happened was that the HIV P24 testing actually shortened the window period from 22 days that we saw with the third generation HIV testing to about 16 days. And it can be detected even before seroconversion occurs. So this can be even before cell conversion occurs. So these days the combined HIV testing, we have combined HIV testing. They use P24 as now P24. What they do now is that they add P24 to this third generation and making it fourth generation now. So now the fourth generation HIV tests include HIV P24 and third generation um, HIV 1 and 2 antibodies, thereby cutting down everything to around 16 days. In fact, even very, very short now. Then finally, we now, like I mentioned to you now, we now have the HIV nucleic acid test, which has shortened it now. The shortest window right now, which is 10 to 11 days. It can detect tiny amounts of viral RNA even before they become high enough. They have to the virus has to compound everything before it compounds everything to become high enough to be for even before P24 even begins to appear in the blood. you know it can pick up the RNA of the virus. So what they do right now is that they'll pick a pool of 16 donated units. You know that when you donate blood, they have these what's it called, thing that's attached to it called a segment. They will draw 16 blood from 16 segments and then test it together. If any of the pool tests positive for HIV, they do NAT testing. If any of them becomes positive, then they will now start testing one by one to narrow it down. These people, they can people donate blood a lot, so they don't go around trying to test all the units of blood. They bring 16 pools together, 16 donations together, pull all the blood from it, test it. If it's positive, then they'll begin to try to search which of the units is particularly positive to reduce their workload and all that. And now historically, we already mentioned these surrogates for. Historically, we already mentioned these surrogates that were used for HIV testing, such as anti-core antibody CD4, CD8, which are now obsolete. Now, so like we said, NAT is required for HIV, HBV, HCV, and West Nile virus. Okay, and usually West Nile virus is usually during the mosquito season in some centers. NAT is not done for syphilis. NAT is not done for HTLV1. Okay, because this ones are serology testings only. Normally, after we review the slide, I will start to see if there's anything we are missing, and I think that's basically all we need to know for now concerning these ones. Let's go to the next slide. So now come to let me see. Hey, folks, I would have seen. I see. I missed the slide now. We now come to platelets plus bacteria. What to do when a culture becomes positive after release? There's another blood product we'll talk about quickly, which is platelets. When you donate platelets, either by pooling or by platelet placement plus platelet pheresis, remember that the main thing you are concerned about is bacterial contamination. The most common transmissible infection in platelet delivery or donation is actually bacteria. Platelets are usually stored at room temperature around 20 to 24 degrees centigrade for up to 5 days. So take note of that. So you store platelet for up to 5 days. And remember that platelet is not stored in the cold. What you store in the cold is red blood cells. Red blood cells is 1 to 6 degrees centigrade. We keep measuring these things until we become familiar with them. So platelet is stored at room temperature at 20 to 24 degrees centigrade. Some nurses are kind of used to the fact that every blood product are stored in the cold. So when they come to pick up platelets, you have to let them know so that especially a new nurse, they may pick up the platelets and put it in a in a cooler with ice and everything. The problem with that is that will inactivate the platelets and make them not to function. So they will not be able to function as they will not be able to cause blood clotting. You know, usually platelets when they are placed in the cold becomes inactivated, shortening their lifespan to 1 day instead of 5 to 7 days. So when you transfuse it after like the second day, the person may not be able to function very well again. That's why some people are actually testing out frozen platelets because they say it can be used in emergency setting. If somebody is bleeding and is going to die now, you can actually give the person maybe frozen platelets or something like that to arrest that blood at that point in time. I'm knowing fully well that after that first few hours, you need to give another platelet that is at room temperature. To sustain the person for a longer time. But at least for the immediate time, if you have frozen platelets instead of throwing platelets that are 7 days old away. The problem is that, well, um, have platelets, you have to test platelets for bacteria. Once you collect platelets from a patient, either from apheresis, use a machine to collect blood, sort out only platelets and return the rest of the blood product to the person, or using pooled blood platelets. In pooled blood platelets, what you do is that you take like 5 to 6 units of platelets and then pull it together, and sorry, of red blood cells, of I mean whole blood, then pull it together and get platelets from it or something like that. You know. So what each of them you have to in the last 5 to 7 days. Usually, once you collect the platelets and you have put it at room temperature, you have to be agitating it. If you go to your blood bank, you see there's this machine that agitates platelets, to prevent anything from degranulating or some not degranulating, but to prevent some kind of um clotting related issue or so. So you have to be shaking all the time. So platelets has to be, yeah, platelets has to be agitated when placed at body at room temperature. Okay. Now, once you do that, then you have to 24 hours after collecting that platelet, you have to actually do test for bacteria because bacteria would have had time to proliferate. You could do a culture, a sterile culture, you know there's an automated culture system. So you and I, whatever you call, you take some platelets, infuse it into a blood culture bottle and keep for 5 days. Every day you have to be looking to see if the culture tested positive or not. So you often culture sampling, culture occurs 24 hours post collection. In the US culture based system. Now, if within that 5 days the platelet bacterial culture turns positive, then the first thing you must do is to try to retrieve it. You keep the culture for 5 days. If it turns positive, after that, you attempt immediate retrieval. What is immediate retrieval? Immediate retrieval means that when this platelet turns positive, when this culture from the platelet turns positive, you don't want this to be given to the patient. You reach out to the blood, you reach out to the blood bank and say platelet so and so, we are from microbiology, platelet so and so culture has turned positive. Okay, so the blood bank will quickly try to look at that platelet in their inventory. If that platelet has been given to a patient, then that patient will have to culture the patient's blood, monitor the patient, to make sure that this patient has not received the infectious disease or bacterial transmission, through platelets. And then how do you do that? You notify the patient's physician, especially if it's an inpatient. Now, there are some conditions, or sometimes when you are lucky enough and this platelet has not been actually given to the patient. So, what do? You quickly retrieve that platelet. You want to work very hard, fight hard, retrieve the platelet. When you retrieve the platelet, what do? You reculture the unit. That same unit, you reculture it again. You want to identify the organism, and then you culture the unit from the blood bank, and also look at the one that is also you already culture. You culture it again and try to retrieve the organism. If it's a skin contaminant, then that's not a problem. You take it back. Skin contaminants doesn't mean that the platelet is is infected. It's just that some flora from the skin contaminated during the blood transfusion. So usually, skin flora is the usual contaminant, and then so that one is not a major issue. But if it's a real organism that is not maybe staphylococcus, streptococcus, or let me say some real organism, that is growing in it, then because you've not given this blood to the patient, and you've retrieved sorry, this platelet, you're not giving to the patient, and you've been able to successfully retrieve it, you have to reach out to the donor and say, "Hi, donor, the blood culture we did. Um, by the way, sorry, sorry, sorry. By the way, once you retrieve it, I think you have to discard it because bacteria is growing in it, whether it's skin or not. What we are concerned about is the donor. If you have no if you're not able to retrieve it and it goes to the patient, you have to worry about the patient, culture the patient's blood. But if you're able to retrieve the unit and the unit, retrieve the unit because the culture from that unit shows positive, then you're worried about the donor this time around. You call the donor and say, donor, before you call the donor, you want to see if it's a skin contaminant. If it's a skin contaminant, then that donor is healthy. It's just that his skin normal flora contaminated the platelet. I think you may have to discard the platelets all the same. But if this is not a skin contaminant, that is real bacteria, then this patient has that your donor has an asymptomatic bacteremia. So, and you don't want him to donate again. Not only that, you want to also make sure he gets medical attention. Maybe there's an occult ongoing infection that has not become very apparent in this particular donor. So the most common transfusion transmitted infection risk today is in platelets. It's actually bacteria. Bacteria is actually more common than viral transmissions right now in the United States in terms of for platelet transfusion. And remember that one of the reasons is because platelets are stored at room temperature and all that. So that's why there are very well defined standards, you know, to test for platelets, you know, to do storage. So they make FDA and FDA guidances of 2021 and AABB standards using this culture 24 hours after collecting platelets. You culture it and put it in the microbiology to see, when you put this in the culture bottle, you put it in this machine, and if anything grows, the machine will make a beep sound. And that's what they do in microbiology. And then sometimes some people are now doing what we call extended platelets. Normal platelets half life is 4 to 5 days, but people are now like we want to extend it to 7 days. So if you want to extend it to 7 days, then on day four, a day before it expires, or day five when it's expiring, take another culture again. Do a secondary testing. You know, you could do a secondary testing or thereabout to see if you can extend it. I mean, if it doesn't grow anything, I think day four, if it doesn't grow anything, then you can extend it to day seven and all that. Okay. However, there's some people that are not doing that already. What they're doing now, this is look complicated, but at least you hear it for the first time. You hear it again and again. What some people do now, they do what they call they use surreal to ultraviolet kind of light or something to shine through it, or let's say, I don't want to say irradiate. Use suralin, call it suralin treated, what they call pathogen reduced platelets, because platelets are prone to bacterial pathogens. Then I will call pathogen reduced platelets by using suralin to kind of treat it with suralin. So on day two, they collect the blood and then they treat it with suralin. So in that case, they are if it's suralin treated and is culture negative and suralin treated, it can be able to stay up to 7 days, from 5 to 7 days. Um, Usually, those ones, the way Soralin works is that Soralin inactivates all the DNA, all the DNA in that sample. So that means if there are viruses, it can inactivate it. If there are bacteria have DNA, it inactivates it. If there are white blood cells, inactivate it. White blood cells in the problem, no, white blood cells are not normally found in platelets, but can be found in red cells. Now white blood cells or small amount of platelets White blood cells, the problem is that they can cause graft versus host disease. And especially, a white blood cell, when you transfuse blood products, you shouldn't have a lot of white blood cells. But if you have white blood cells, what happens is that your immune system, targets the white blood cells and destroy the white blood cells. But sometimes, if these white blood cells are not destroyed, they can get implanted into the bone marrow if they're not destroyed. And then these white blood cells, remember that white blood cells are soldiers and they begin to destroy the bone marrow. What they call transfusion associated graft versus host disease. The white blood cell will graft into the bone marrow and begins to destroy the bone marrow and scatter everything in the bone marrow, causing problems. So that's why in the United States of America, all transfusion products, especially red cells, are actually irradiated. Irradiation inactivates white blood cells so that they're not able to cause transfusion associated graft versus host disease. Sorrelin also that is used for platelet can also inactivate white blood cells because it generally inactivates DNA. And not only that, you don't want antibodies to be to be developed against the white blood cell, what we call HLA antibodies, human leukocyte antibodies. The antibodies make it, has a lot of problems. Number one, they can make it difficult for someone to receive platelets. If somebody has HLA antibodies, you give the person platelet, they may have platelet refractoriness. Platelet refractoriness means that when you give the person platelets, it will not stay. If somebody is 10,000, normal platelets is 150,000, and somebody has 10,000 platelets unit, 10,000 in the blood, and then you give him platelets. It goes up to 11,000, comes back to 5,000. You give him that one, it goes to 5 and comes back. It's not really improving. The platelet refractoriness that can be as a result of HLA antibodies, maybe previous transfusions, antibodies are developed against the white blood cells that were in those products. So that's why I want to irradiate. You also want to leukoreduce, we call leukoreduction. But we'll come to others. That's for red cells. I mean, that's for other products. We'll come to that later. So the coming back to platelets, we've seen the protocols that if you culture on 24 hours after collecting the platelet, and if there's anything that turns positive, the first thing you have to do immediately attempt to retrieve the unit. If it has been given to the patient already, inform the patient's clinician. Um, and the patient should be monitored and they'll be treated. But if you're able to retrieve the unit, then test it for skin flora versus real pathogen. A lot of times, about two-thirds of the time, the old initial positives are as a result of skin contamination. So it's not a really true positive. But if you see real organisms, staph, salmonella, and all those things, then in that case, you are dealing with a real occult bacteremia, and you have to inform the donor. And then but if you try to retrieve it and the patient is actively receiving that platelet, please stop the transfusion and retrieve that platelet as much as possible. We want to prevent harm to the patient. Okay, so let's go to CMV, cytomegalovirus. If you notice, in our major testing for HIV, I mean for injections of, testing donor blood, we mentioned HIV, HCV, HPV, and then human T cell lymphocytic virus. We mentioned syphilis serology, Babesia in endemic areas. We mentioned Trypanosoma cruzi in people, Trypanosoma cruzi. You know that it's done only once. That is the first time tester. We usually mention CMV, but somehow, CMV is cytomegalovirus. It's a herpes virus, just like HSV. However, it resides. The thing is that it causes lifelong latency in most individuals, meaning that a lot of people in their lifetime will have CMV and they will never ever ever develop any symptoms. So it causes lifetime latency, and there is a lifelong latent infection. And the US, a large proportion of the US adults have CMV. I think about 50 to 80% of all donors have CMV in their CMV virus. The CMV is not usually a problem unless someone becomes immunocompromised. Then CMV will cause problems. Remember in our GI section, we began to see CMV, in the esophagus and all that, which I told you, invades the stroma and the blood vessels deep thereabouts. So CMV resides, and then the next thing you want to know about CMV What about in the blood? In the blood, CMV resides inside white blood cells. So CMV resides inside white blood cells. So remember, the question comes to you now. So if somebody has CMV and this person you give CMV containing blood to most people, it will not be a problem because most people are already positive for CMV. But there's some people who don't want to give CMV infected blood. These are newborn babies. We don't want them, especially neonates. The immune system is not yet strong. We don't want to give them, intrauterine transfusion. We don't want to give them CMV. Somebody that is immunocompromised, organ transplant recipient that is negative for CMV. If somebody is already positive for CMV, they give the person CMV blood. That's not a problem. But if somebody is negative for CMV, is immunocompromised, has HIV, all those kind of things, you don't want to give the person CMV containing blood. And that's why the issue of CMV is now an issue in the United States. So CMV resides inside white blood cells, and usually it can be transmitted by cellular products, um, like like red blood cells. Red blood cells have small amounts of white blood cells in them. Platelets have small amounts of white blood cells in them. Granulocytes also have a lot of white blood cells in them. Granulocytes is the king of white blood cells. Granulocytes themselves are white blood cells. So all these products can contain some amount of CMV in them because of the varying amount of tiny amount of white blood cells they may contain in them. Now, the exam may ask you which of these may transmit CMV. Of course, red blood cell concentrate, packed what we call PRBC, packed red blood cell, platelets, granulocytes. But the mention fresh frozen plasma or cryoprecipitate, the answer will be no. Remember that these are not cellular products. Plasma is just free fluid after you have spun down all the cells and the platelets down. So you see, fresh frozen plasma will not transmit CMV, you know, because it has no intact cells. These are just cell-free fluid. Unless you didn't, the fresh frozen plasma was not well prepared and is contaminated by cellular areas of the blood. You spin down the blood, the plasma up is fresh frozen plasma. That's when the way you produce fresh frozen plasma is that when you collect whole blood, you spin it. Then when you spin it, fresh plasma will be above. Then they count that plasma or collect that plasma, and then you freeze it within 8 hours. If you freeze it within 8 hours, it is called fresh frozen plasma. If you freeze it within 24 hours, but we are not able to get into the 8 hours window, then call it PF24. That is frozen plasma at 24 hours. Within 24 hours, all of them can be stored up to 1 year. At less than less than or equal to minus 18 degrees centigrade and lower. Some will store up to minus 30 degrees centigrade for up to 1 year, and then that's what you do. You store it for up to 1 year, and then it usually contain clotting factors and all that. And from fresh frozen plasma is where you make cryoprecipitate also, which we're going to discuss later. So those ones, fresh frozen plasma and the rest, they don't contain CMV because they're not cellular products. So most people in the population are CMV positive. So like I said earlier, CMV is for people who are negative. So what kind of testing is done? It is not NAT. I mentioned to you already where you do NAT, nucleic acid testing. It's for HIV, it's for HCV, it's for HBV, for West Nile virus. Serologies are done for syphilis. Serology is done for HTLV 1 and 2. Then Babesia can also do NAT as well. You can also do NAT in Babesia. However, Trypanosoma cruzi, I'm not sure how they do the test. Maybe they do serology for that. But when it comes to CMV, it is a serological test. You look for the antibodies. Presence of antibodies shows previous infections. So, and if a blood product is CMV negative, the blood center will label the unit as CMV seronegative. You know, and that means they've tested it for CMV IgG, IgM. You can set it aside for neonatal problem, neonates, or for people that have a significant immunocompromise. The question is this: what do we now do for people that what do we now do for how do we now reduce CMV transmission generally? Even though so the thing is that there's a general precaution in the United States that is done to reduce CMV transmission generally, and that is called leukoreduction. Leukoreduction. Remember that CMV homes itself, it stays inside white blood cells. So if you can reduce the amount of white blood cells in your blood product, then that will help a lot. So normally when they collect blood, the blood in the blood center goes to a filter. That filter can allow red blood cells to pass because red blood cells are tiny. Can allow platelets to pass because platelets are tiny. Only like 10 microns or thereabouts. But it does not allow white blood cells to pass through. So as a result of that, white blood cells will filter that. We call that leukoreduction. And leukoreduction, when you filter out white blood cells, guess what? You would have significantly decreased the amount of CMV in that blood product. So, in fact, research has shown that this leukoreduction can reduce CMV transmission by 99.9% because a leukoreduction, especially in the blood center, can reduce CMV transmission by 99.9%. Blood center we do have a lot of quality assurance and all that. You know, you know that you can also do leukoreduction by the bedside. When you go to give somebody blood, they will have all these filters that give blood. You can use a filter that is much tinier that allows the red cells to pass through but not white blood cells. But that's not good. I think it's better you do the leukoreduction reduction before you send the blood from blood bank to the hospital rather than allowing the nurses to use different kinds of filters to filter it when they are giving the blood directly. Remember that they cannot set up QC. They don't have all the standardized ways of ensuring that they achieve good success. So it's always good to do donor or blood bank leuko reduction. So when you do leuko reduction, you know, it is comparable to CMV negative donor blood. There's some people, CMV negative, if somebody that doesn't have CMV antibodies, leuko reduction is equivalent to that kind of blood. So it's leuko reduced bloods are actually CMV safe. And and it's better that so some people now in the United States, almost all blood products that contain like red blood cells, platelets, and granulocytes. No, not granulocytes. You cannot do leukoreduction reduction on granulocytes because granulocytes themselves are white blood cells. But especially red blood cell products, you want to leukoreduce reduce all of them. That's why you will see somebody saying that this is a leukoreduced reduced irradiated, leukoreduced and irradiated red blood cell product, packed red blood cell. Remember that irradiation has a different purpose. It inactivates white blood cells. Why? To prevent grafting of the white blood cells in the bone marrow, graft versus host disease. Whereas leukoreduction is mainly concerned about CMV, eliminating the white blood cells, filtering them out so that they don't have white blood cells that can transmit CMV to your patient. And that for concerning that. Okay, so I think that's basically it for now. So let's see what we can do about the next slide. And next slide, look at emerging infections, arboviruses versus babesia, and we'll look at try to fill up our gaps, knowledges in the different sections. So pay attention to the slide. So most of the things I'm going to see are going to be on the slides. By the way, what are arboviruses? Arboviruses are viruses that are transmitted by arthropod vectors like mosquitoes, usually. For example, the West Nile virus, the Zika virus, the dengue fever transmitted by Culex mosquito, the chikungunya virus. These are these viruses that are transmitted by um by arthropod mosquitoes. These are called arboviruses. There used to be a concern for there used to be we used to be concerned about them in transfusion medicine for a while because these viruses, when they get to the patient, they'll cause transient viremia, hairy people. You know, and then when these healthy people donate blood, it will be transmitted to the patient, and if the patient is immunocompromised, the patient may be in trouble. So Zika virus, if you transmit it to a woman, a pregnant woman, is going to cause congenital malformations in the woman that is pregnant. So actually, there was a West Nile virus outbreak in the United States in 2022, and it was a major West Nile epidemic, and it was found to be transfusion transmissible, and that was also led to the implementation of the nucleic acid testing in 2003 for West Nile virus. So don't forget, I've mentioned times with that number that nucleic acid testing is very highly sensitive. It's done for HIV, HCV, HBV, and West Nile virus. as well. There's not done for HTLV 1 and 2. That's serology. Syphilis is serology. Babesia is also, you also do NAT for Babesia. There's something we mentioned recently. CMV is also serology. We will do antibodies for CMV. So we see that Zika virus also caused concerns, but that was far. It was in 2016. They did Zika virus nucleic acid testing, and all that. But I think right now they have stopped Zika virus. Okay. Dengue fever, chikungunya fever. Those ones are more common in South Asia and thereabout. Those ones, there's no testing for them in the United States. When somebody goes to the new blood, nobody tests for dengue, nobody tests for chikungunya and all that. Arbovirus is typically during the period of transient. Now, if you look at all these viruses, arbovirus, especially West Nile virus, they cause acute viral infections. Unlike HIV and hepatitis that cause chronic viral infections. So the way they do it is this: it's not as if they test every donor for West Nile virus or anything. They do pools. Just like we mentioned for HIV, they just pool like 16 units of blood, test it for HIV using NAT. If it is NAT negative, then okay, we'll move ahead. If it's positive, then we'll have to calm down and look for which particular unit will give us the positivity. Then West Nile virus is done with NAT. You do mini pools in low season. They have seasons of those mosquitoes when mosquitoes kind of grow. So in seasons where there are no more significant mosquitoes, the West Nile virus NAT, in the blood bank, in the Red Cross Center where they do the donations, they will test pools of blood. They'll pool blood together and test it. You know, but if it is in the season where a lot of WNV infection or a lot of mosquitoes during the breeding season or the seasonal period for the WNV, they may have to test each donor in that area individually. Babesia is a protozoan, that causes babesiosis, just like Plasmodium falciparum is a protozoan. Babesia is not transmitted by mosquitoes, so it's not really an arbovirus. So we mentioned it's not an arbovirus. So it's transmitted by the exotic tick, the same tick that causes Lyme disease or thereabout, Borrelia burgdorferi. It's one of the most common. So Babesia is one of the most common transfusion transmitted parasite in the USA historically. We've heard of platelet transmitting bacteria, we've heard of HIV, HCV. Those are all viruses. If you about parasite transmission in the United States, the number one parasite transmission is going to be Babesia. There are some geographic areas where you have Babesia, and FDA has also approved a lot of Babesia nucleic acid tests, in endemic areas like in the New England here where I am, like New Hampshire, Massachusetts, Rhode Island, or the whole of New England, and the Upper Midwest. They perform Babesia testing on all the donations. The all donations that come from New England. So if you are New England, Connecticut, um, Vermont, you know, all these places, you have to do all the blood that is donated in that place. They have to do Babesia testing. So, but if you are in areas where Babesia is not very common, they may not do it. So, this is a regional issue when it comes to Babesia. It's still an emerging infection, that causes asymptomatic infection in donors, but sometimes it can cause real problems as well. Malaria, like I mentioned again, malaria and CJD, crofel Jacob disease is not tested. For the thing is about malaria is this, they use deferral. If you ever lived in a malaria endemic area and you come to the United States, you have automatic 3 months deferral, meaning that within that 3 months you cannot not 3 months, 3 years deferral. Like those of us that come from Nigeria, you cannot donate blood in the United States for about 3 years because you lived in malaria area. If you went to visit and came back before, they give you 12, they give you 3 months deferral. Per the current FDA guidance, it's actually at around 3 months. Before it used to be like 12-month deferral. Deferral means you can't donate blood for that period of time. If you just visited Nigeria or malaria endemic area, you had 12 months. But now they've reduced it to 3 months for just visitors who maybe spend like 2 weeks or thereabout. you know. But those of us that live there for a long time is 3 years. deferral. And then if you ever lived in the then for Creutzfeldt Jacob disease, CGD, that causes prion disease, affects the brain. It's a kind of a prion. They call it prion. It's neither a virus nor bacteria. Like a protein that can cause infection, protein that can invade. Prion that causes some kind of encephalitis or what they call mad cow disease. You know, it causes BSE. Where do we let's see, BSE in CGD. That sorry, BSE in CGD. Let me see the. I've forgotten the listing. Um, yes, BSE is bovine spongiform encephalopathy. It's associated with cattle. Yes, bovine spongiform encephalopathy. What they call mad cow disease, bovine spongiform encephalopathy. Anybody who has ever lived in the United Kingdom between 1980 to 1996, or who have lived for greater than 5 years in France, anybody who has lived in the United Kingdom between that time is permanently deferred. We never ever been able to donate blood. There's no blood test right now for Jacob disease screening. So the main thing is history. Somebody that lived in the UK 1980 to 1996, person has permanent deferral. I'm not able to donate blood because that was a period of the mad cow disease, the prion that we talked about up to 1996 or thereabout. So I think basically that's it for this case. So to recap the entire section, um, for donor infectious disease screening and eligibility, because this section was about disease screening and donor infectious disease screening and eligibility. Every donor is going to be tested for HIV, for HPV, for HBV, for HCV, HTLV 1 and 2, syphilis, and West Nile virus. Then trypanosoma cruzi is done only once. Then the first time the person is going to donate. And Babesia is done based on regions. For example, now in New England, we do Babesia testing for people that have Babesia. I mean, just to look out for Babesia. And then you also need to know about nucleic acid testing, which has significantly shortened the window period for HIV and other things. HIV used to take like 56 days to turn positive, giving a long window period of 2 to 3 months. But now with nucleic acid testing, within 10 days, it can actually become positive, even better than P24, which used to be 16 days, or HIV 1 and 2 antibodies, which used to be 22 days. And then there's no testing for malaria or prions, okay? Those of donor deferral, remember that if somebody has traveled to malaria endemic area, you defer the person donation for 3 months. Any hepatitis after age 11 is permanent deferral. If someone has ever had hepatitis, even if the person recovered, is permanent deferral. Because the reason is because hepatitis B core antigen will be present in people who naturally recover from the infection, and there's no way you will know if somebody has HB core antibody. There's no way you will know whether it is. There's no way you will know whether that infection is because core antibody doesn't tell you whether it's active or whether the person has recovered. So any hepatitis at all is just know it is permanent deferral in the United States. And then any recent tattoo, they will ask you recent tattoo. The question is the tattoo from a government sanctioned area or from a government or area that the government does not sanction or something like that? Is it from a government sanctioned area or not? Okay. If it's from a government sanction, I mean government approved area. If it's from government approved area, the person is doing the tattoo, then the deferral is not going to take place. So you can allow the person to donate blood because they use sterile equipment and all that. Somebody can do tattoo in government approved centers. If it's not a government approved center, then it's 3 months deferral. Then certain medications, if somebody is on painful medication as you treat knowing is 1 month deferral. Warfarin is 7 days deferral and all that. And then talk about CMV safe blood. Talk about CMV safe. Talk about CMV. Sorry. CMV is the way we deal with CMV is to do leukoreduction, and the leukoreduction is equivalent to CMV negative blood. and to prevent CMV transmission. They'll talk about platelet the bacteria testing. That 24 hours after collecting platelets, you have to test it and determine if you are going to donate, if you're going to transmit this. Test it and see if there's any bacteria. There's bacteria, you try to record the platelets, and the protocols we followed whenever we tried to record the platelets and all that. So remember that somebody has gone to prison. Somebody has been to prison somebody goes to prison for 72 hours. The person has to have 12 months deferral. So what is deferral? You need to just memorize it and all that. But if somebody are going to prison, 12-month deferral. There are many medications. Watch Go back to our last videos, you will see issues about deferral for blood donation. Look at this question. Can anybody attempt it? If you are with me, can you attempt this question? What would be your answer? Okay, because of time, I'm going to pick it up. Okay. You don't know it's jailed for 24 hours. What is the deferral? I mean, how long will it stay before it donates blood again? The answer is none. Because normally for people who have been incarcerated for more than 72 hours, they have 12 months deferral. But this person is 24 hours. It's not up to it's up to 72 hours. And because of that, the person is free to donate blood. But if the person is incarcerated for up to 72 hours, the person has to wait for 12 months from the time the person is released from jail. You know, if any prisoner who has stayed for more than 3 days in jail must wait for at least one full year before they can donate blood again. This is because you want to make sure that if there are any things that they have taken before, you want to make sure that you can test them after 1 year for any positivity and all that. And remember, there are some drugs too that don't allow that, like etretinate. Etretinate used to be used for psoriasis. Is a kind of medication that used to treat psoriasis off the market. That's permanent deferral. So all these deferral questions, don't forget them and all that. 3 years is for we mentioned that times without number. So having said that, I think remember that some people now one of the things you have to know permanent deferrals. Permanent deferrals CJD is permanent deferral. Somebody who has ever lived in Europe 1980 to 1996 is permanent deferral. Then what else again? Then people who are using injection drug use, permanent deferral. Commercial sex workers, permanent deferral, and all that. So let's go to the next question. I think we've done this already. Now let's quickly look at this, quickly review this again, and okay. Let's quickly look at this interdonation interval and who is eligible. Interdonation interval and who is eligible. So, which of the following people is eligible for blood transfusion? Platelet donated. Now, we mentioned, I think we talked about this before. When you donate platelets, you are free to donate after 2 days. You are free to donate platelets after 2 days. Okay. So the first option is wrong because this person donated platelet 26 hours ago. The only time you can donate platelets again is after 48 hours. The second question is frequent plasma donation 37 hours ago. The same thing, plasma and platelets follow the same time rule. If somebody donates platelet or plasma, the person has to wait for at least 48 hours. At least 48 hours or 2 days. Sometimes they can change it from hours to days before they can donate plasma or platelets again. Whole blood donated 55 days ago. They want to donate platelet today. No, it's wrong. The thing is that blood, if you donate whole blood, the person has to wait for 56 days, not 55 days. Here they use no, the blood exam, they want to put all these small things to capture people. It's not 55, it's 56 days. And now they put it is 6 weeks. 8 weeks, sorry. 8 weeks or 2 months, you know. 8 weeks. Okay. The answer is eight. Sorry, the answer is 8 weeks. So 8 weeks or 56 days. And within that time, you cannot donate any other blood product, whether it's platelets, whether it's plasma, you cannot donate it. So it's 56 days or 8 weeks that you have to wait before you donate another blood product. Platelets donated 13 days ago, and the person wants to donate blood today. Correct. Somebody who donated platelets after 2 days, you are free to donate. However, there are still some rules. Platelets and plasma, you can donate after 2 days, but not more than twice a week. So after 2 days, for not more than 2 times in a week, and not more than 24 times in a year. Two every 2 days, no more than twice. Sometimes there are these companies that sell plasma. If you go, they'll be attracting you. They'll tell you if you come, they'll give you $600 if you donate plasma. When you go the first time, they'll give you $600. You become so hooked up because you're interested. How can I go again and again? But when you keep going now, they'll be reducing the money until they'll give you only $50. So for every donation, they give you $50. So that means the maximum you can get in a week is $100 because you cannot donate more than twice in a week, and it has to be at least 48 hours apart. You donate on Monday, you donate on Friday. Okay, so you have to donate like that, and then the and that means maximum of $400 in a maximum of $400 in a month or something like that. At least they will attract you initially. So, but you cannot do more than 24 donations in a year. So that means you cannot get more than total of 1,200 or thereabout. I think 50 times 20 is like 1,000. That's $1,200 maximum you can get in a year on all the donations. So at least it's really good at the first time. But at least the reason why you're doing this is just to help people. It's not as if you are trying to use it to make money or thereabouts. Okay. So now there's what we call double red cell, double red cell donation. Somebody will go to donate blood, and normally we donate whole blood. If you donate whole blood, you wait for 56 days before you donate anything again. But if you donate, they do call red, if resist 2 units red blood cell donation, in that you don't donate whole blood, but you donate only red cells, and they're able to remove an equivalent of 2 red cell units. They have to multiply the 56 days by two. If you donate 2 pints of blood, I mean two red cells, then you have to wait for at least 112 days, 56 times 212 days before you can donate blood again. Just so you know. But a lot of times I think people may not even want to collect 2 units of blood from one person. You may push the person to anemia and thereabouts. Why not take it every 56 days? The person can come back after 56 days instead of collecting 2 units and then say come back after 112 days. Okay. So that's the major thing about that. So which of these is going to give you which of these screening tests? Which screening test among those required by the FDA yields the shortest window period for HIV detection? The answer is I've said it time without number is HIV nucleic acid test. The old test ELISA, HIV nucleic acid test can detect within the first 10 to 11 days of the window period. Okay. Um, if you look at the old test ELISA, enzyme link immunohistochemistry, that one is 56 days. The origin is 1980s. That's why they used to see the window period of HIV is 56 days. It was only 56 days because of they used to say it's 2 or 3 months, and somebody can have HIV. It should not become positive until after 3 months. It's because they were using ELISA in the 80s. Then after that came forth the second generation, then the third generation, which I talked to you about, and then came for the HIV P24 antigen, which I think they use for fourth generation or so, HIV P24. HIV P24, the I'll level it now. First generation is ELISA. Then the second generation, HIV P24 is like 16 days. CD4, CD8, that's historical. Just for a story, you mentioned that story again before. HIV nucleic acid test, then this core antibody and CD4 to CD8 was when they didn't have any test at all for HIV. They were using it as surrogate markers to see if somebody can be at risk of HIV or thereabout. And if the CD4 count, as you could detect AIDS, at that point they were diagnosing AIDS self, not even HIV, AIDS. The CD4 counts has fallen and all that. That's what they know the person has HIV. I mean, it was that bad, but now they have good tests for it. Okay, so HIV nucleic acid testing can also be used to test for hepatitis B virus. If for hepatitis B virus, before when you're looking for the surface antigen, it takes like 35 to 50 days, almost 2 months before the surface antigen for hepatitis B virus can become positive. But with the nucleic acid testing, NAT for hepatitis B virus right now, it has cut it down to 20 to 30 days. I would say it's an improvement. It may not be as dramatic as that of HIV, but it's still something. 20 to 30 days from 35 to 50 days. And then we'll talk about HCV. We'll talk about HCV. HCV is the one that has dramatic improvement. HCV antibody used to appear after 70 days of hepatitis C virus infection. But with the nucleic acid testing now, you can pick it up within 7 to 10 days. That's the area where you have significant improvement. I mean, that is massive from 70 days to 7 days. More than maybe 600, 700% cut down in the time. Now, there's a terminology I want to introduce you to. It's called NAT yield. I don't know if it's here. It's called NAT yield. Look at it this way. When people used to use ELISA to detect HIV, somebody will come in to donate blood. And when this person donates blood, they will do ELISA test to be negative. Because it takes 56 days for ELISA to become positive with HIV. So the window period is 56 days. We end up giving this blood that is negative for HIV to a new patient, and then after down the line, these new patients will now develop HIV, even though the patient was given HIV negative blood in quotes. So with the introduction of nucleic acid testing right now, the window period has been shortened to 10 to 11 days. So many people that would have bypassed or slipped under the screening for HIV can now be detected with nucleic acid testing. So if we do a test and NAT is positive, we call it NAT yield. NAT yield, it refers to the amount of cases we are now able to prevent that we were not able to prevent before. So NAT is now yielding a lot of people that can be pulled out of the donor pool that we're not able to get before. That's what we call NAT yield case. So the more NAT yield case you have, the more we rejoice that NAT came into place. Of course, if NAT is positive, you still have to confirm it with confirmatory tests to make sure it wasn't a false positive, you know. But it has cut down the amount of HIV transmission now from blood transfusion to about 1 to 2 million or even less. You know, that's how wonderful, that's how huge, you know, the impact of nucleic acid testing for HIV, is. Let me see. And then now having done that, I think we are done with that for now. I will now go to core components, manufacturing, and storage. This is a very important aspect of blood bank now. You'll be hearing all the kind of blood products. The question is, how do we make all these blood products? How do we make them? Component manufacturing and storage. When a patient donates whole blood, WB stands for whole blood. When someone donates whole blood, the whole blood can be broken down into components. There are three main components. Actually, you can get up to four components because granulocytes. No, you don't get granulocyte from whole blood. Sorry. Whole blood. When somebody donates blood, there are three main components you can get. One is red blood cells. Then the second one is plasma. The third one is platelets. So three citrins, red blood cells, what they call packed red blood cells. Second one is plasma, and the third one is platelets. So one donation can yield multiple products at the same time. So that's what you have to know. And you know, there's what we call apheresis now. Apheresis means that you don't want to collect whole blood and split it up. Normally, a lot of people would donate whole blood and then they split it up into red blood cell, plasma, and platelets. But in apheresis, you want to collect only a single component, either apheresis for red blood cells, or apheresis for plasma only, or apheresis for platelets. For plasma apheresis, we call it plasma pheresis. For platelet apheresis, we call it platelet pheresis. And then what happens is that the machine will be connected to a big machine, one on the right, one on the left, two veins or thereabout. And then the blood will be now one of the it will pull the blood from one of your arms. Let's say you connect, you can Google it on Google now. Just Google apheresis. You see a patient sitting on a couch or on a bed, and then there are two machine connecting two veins, one on the right, one on the left. We pull the blood, for instance, from the one on the left, then separate out all the bring out plasma, and then separate out only plasma, and then return every other thing apart from plasma to the machine. Your blood will just be the machine just like a dialysis machine. Your blood will just be flowing, separating out just plasma. And then the day person will donate pure plasma. When that plasma is frozen within 24 hours, sorry, within 8 hours, it's called fresh frozen plasma. And it can be stored at minus 18 degrees centigrade for up to 1 year. If they couldn't make it in the first 8 hours to freeze it, but they're able to freeze it after, before 24 hours, they call it PF24. As plasma frozen at within 24 hours, PF24, but it's not fresh frozen plasma. For it to be fresh frozen plasma, it means within 8 hours it has to be frozen. So platelet pheresis now, there are some standards for platelet pheresis. For when you donate platelet, the platelet must have a certain count. All these things are blood bank questions. They ask you this in RISE exam and even in real life. So they for 1 unit of platelet from apheresis must contain greater than or equal to 3 times 10 raised to power 11. I'm sorry, it's not on my slide, but when we get to the real blood company, this in this introductory lecture, when we get to the real deal, deal with all these things one by one. It will contain greater than 3 times 10 raised to power 11 platelets from one person. Okay. If you do now, if you do apheresis, one human being can give you a complete unit of platelets, and a complete unit of platelets should contain greater than or equal to 3 times 10 raised to power 11 units. Platelets. However, a lot of people can get platelets, what we call pooled platelets. Pooled platelets means that we get pooled platelets means that we get whole blood. I will separate the whole blood into red blood cells, into plasma, into platelets. And then the platelets that you need to make 1 unit of platelet from pooled blood is like 5 to 6 units of pooled blood. So if somebody if you get 5 donors, 5 to 6 donor whole blood. So that whole blood you can make out if you pull like platelet out of 5 or 6 of them, be able to make 1 unit of platelet. So from pooled blood you can make like 1 unit of platelet from 5 to 6 donors. But from platelet pheresis, you can actually get 1 unit, which is equal to 3 times 10 raised to power 11. Plasmapheresis is the same thing. Plasmapheresis is done when you collect only plasma. Can you collect only red cells? Yes. However, if you want to do normally, instead of collecting only red cells, why don't you do whole blood donation? Most people do whole blood donation. If for any reason you want to do apheresis for red cells, then it has to be what we call double red cell apheresis. Double red cell apheresis means that we are not interested in plasma, we're not interested in we're not interested in plasma, we're not interested in platelets, we want only red cells. The person they collect 2 units of red cells from the person. and that is from one donor. And that means the person have instead of waiting for 56 days before donating blood again, person wait for 112 days before the person can donate blood again. So the other issue we want to look at is the issue of leukoreduction. We mentioned leukoreduction already. That leukoreduction means that circulating the blood. Usually, all this, this the thing is that when you collect blood, the blood there's a main bag, what you call the mother bag, and then there are three other bags that are attached to the mother bag. You can go to Google. It's unfortunate that I didn't put all these pictures here. Sorry about that. Go to Google and Google it. You see they are connected in pipes. As you're collecting the blood, it goes into the mother bag, and then from there we can separate into different other bags that contain different anticoagulant, different things. We can separate into other bags and all that. So, but when you're collecting the blood, you can filter out white blood cells. By filtering out 99.9% of white blood cells, we call that leukoreduction. That and those white blood cells normally contain no blood cells normally contain CMV that can cause CMV infection and immunosuppress people. In people that are healthy, CMV is mainly a latent infection. But liquid reduction is important for three main things. There are three main things, going forward, inter-yearly liquid reduction take of three main things. The first one we talked about is CMV transmission. CMV transmission. That's the first thing we talked about. We'll talk about liquid reduction, CMV transmission. Okay. The second thing I want to talk about is it reduces CMV transmission because CMV lives in white blood cells. The second thing you need to know about is it reduces febrile non-hemolytic transfusion reactions. A lot of times when you're on blood bank call, they will call you that they started giving somebody blood cell product and then the person's having fever you know. And that if it's if you exclude every other thing, there's no evidence of acute hemolytic transfusion reaction, no back pain, no hematuria, DAT, that direct antiglobulin test is negative, you rule out every other thing, sepsis, everything, and it's just an isolated fever. That's febrile hemolytic transfusion reaction, and then you write the transfusion note on that. Remember that febrile hemolytic transfusion reaction is caused by cytokines. When you store red blood cell product, the little white cells in them, they'll releasing cytokines. Releasing cytokines. It's like cytokine storm. So when you now start giving the blood, cytokines will now start causing fever. Cytokines will go and reset the thermostat in the brain and start causing fever in these patients. So what you want to do is when you do liquid reduction, you reduce the amount of white blood cells, 99.9% of white blood cells in the packed red blood cell, packed RBC, and that will make you not to have cytokines. Before now, febrile non-hemolytic transfusion reaction used to be very common, but with universal liquid reduction right now in most centers, that significantly decrease, the amount of febrile non-hemolytic transfusion reactions. If someone is in a center where they don't have leukoreduced red blood cells and people having febrile non-hemolytic transfusion reaction, when you are writing a transfusion note, you write there in a future transfusion should be with leukoreduced red blood cells, you know, that kind of thing. However, with leukoreduced red blood cells, okay. However, but if most times in the US now, everyone gets liquid reduced red blood cells. So now number one, so liquid reduction decreases the chance of CMV transmission, and number two, it decreases febrile non-hemolytic transfusion reactions, and number three, it decreases HLA alloimmunization. Alloimmunization means foreign antibody formation. Remember that white blood cells are glycocytes, so when they get into the blood and they stay there, if they survive and stay there for a long time, our own body will produce antibodies against those white blood cells called HLA antibodies. Like I say, HLA antibodies are dangerous because they can cause HLA alloimmunization. I mean, antibodies, foreign antibodies are generated against human leukocytes, and then that will cause platelet refractoriness, and someone that will not be able to receive platelets well, and also will cause sometimes it also causes um yes, I'll just say HLA immunization. I don't want to mention gravis osseous disease. Gravis osseous disease is a different thing. If you want to prevent gravis osseous disease, you use irradiation. Irradiated red cells, irradiation inactivates the white blood cells. White blood cells, when they are inactivated, will not be able to graft into the person's bone marrow and cause transfusion associated gravis osseous disease. And The issue of storage conditions and return or reissue is heavily standardized. Normally, red blood cells are stored at 1 to 6 degrees centigrade for 42 days. Remember that if you use additives, we'll come to all those ones later. There are different days, where you can store red blood, some 21 days, 35 days, 42 days. These are all exam questions. But if you store red blood cell is normally stored at 1 to 6 degrees centigrade. You don't want bacteria to grow in it. The maximum you can allow is up to 10 degrees centigrade. Anything greater than 10 degrees centigrade is not allowed. So red blood cells are stored at 1 to 6 degrees centigrade. And that's for 42 days if you have an additive, what they call AS additive, which we're going to deal with subsequently. So platelets are, if it's platelets are stored at 20 to 24 degrees centigrade, like we mentioned, for 5 days. And then if you issue a red blood cell, there's some conditions around it. It has to be used up, or if not used up, return within 30 minutes. So that's it. You either use it or return it within 30 minutes. But there are some nuances to all that, which we're going to look at very much in more details subsequently. Look at whole blood processing and mother to daughter bags. Remember, I told you there's a mother bag, which I don't have here, but the mother bag is going to be connected to other bags, which are called daughter bags. Now, what anticoagulant is going to be found in the mother bag? The mother bag, which is the main bag that the donor's blood is going to be going into, is going to contain CPD or CPDA1. CPD, citrate phosphate dextrose. CPDA1 is citrate phosphate dextrose with adenine. Sometimes they may ask you and see what does the A in CPDA stand for? Adenine. So it's the main collection bag. So now the other daughter bags are bags that are connected. They are sterile. They have a closed tubing system. These bags are to allow for separation of components like maybe plasma and platelets for the red cells, and they're usually sterile. Google it and just see blood bank, blood bank or blood bag, mother and daughter bags. You see the way they are connected in a tubing system. Now, so when somebody starts donating blood, the first anticoagulant that the person's blood will meet is CPD or CPDA1. Remember that CPD is can preserve blood can preserve blood for I think for 21 days. CPDA1 can preserve blood for like 35 days. However, when the blood has been when they have finished collecting CPD, citric phosphate dose is 21 days, while CPDA1 is 35 days. Yes. However, when you finish collecting this blood, you have to transfer the blood to the daughter bags. You separate it into components. Now, when you now separate out the red blood cell component, normally you spin it. When you spin it, it's going to settle in three levels. You can Google all these things. The lowest level is going to be red blood cells because it's very dense. Then the upper level is going to be plasma. Plasma is light. Plasma is going to be yellow. If plasma is red, that signifies hemolysis. The way you know that there's hemolysis in blood, if you spin down, you take a patient sample, and then you spin it. Of course, it can be traumatic withdrawal that caused the hemolysis. But whatever the case, how do you know there's hemolysis? When you spin the blood, normally red cells will go down, then the yellow fluid will be up. That's called plasma. And then that plasma, if it is red, it's going to be yellow. But if it's red, that means there's hemolysis. And mind you, there's a difference between plasma and serum. In case you don't know, what is in serum is, plasma contains clotting factors. So serum is plasma minus clotting factors. So when you use a serum is used for chemistry tests. When you use the clot activator bottle, activator bottle will coagulate, when there's coagulation, it coagulates blood. You pull out the clotting factors to coagulate the blood. The fluid that is filtrated after coagulated blood, when you coagulate blood and then the remaining fluid outside of it is called serum. So it's plasma, serum contains no clotting factors, unlike plasma. So plasma can be converted to serum by coagulating it, or something by removing the clotting factors in it. But that's just by the way. Somebody may just ask you, let's say, what's the difference between serum and plasma? Serum is used for chemistry tests a lot of times, and that's why you don't want to use when you do electrophoresis, gel electrophoresis, and all that, you don't want to use plasma for gel electrophoresis. If you use plasma for gel electrophoresis, plasma contains fibrinogen. Fibrinogen is going to precipitate in your gel as though the person has a band or something like that. But that's chemistry. We're going to do chemistry, we deal with all that. Now, so when you spin this your blood product, you have red blood cells at the bottom, plasma at the top. Then in between, what we call a buffer coat. The buffer coat is between the red blood cell the bottom and then the plasma at the top. The buffer coat is where you have the platelets. Okay, so platelets and granulocytes are found in the buffer coats. So you can get the platelets out, get the red cells out. Now, if you're moving the red cells into one of the daughter bags, one of the daughter bags usually contains 100 ml of an additional additive solution called AS. It can be AS1, it can be AS3, it can be AS5, it can be AS7. Usually they are numbered in odd numbers. They are called additive solutions for red blood cells. So AS1, AS3, AS5, AS7, these are additive solutions for red blood cells and they contain nutrients for preservation of red blood cells. Okay, so these additive solutions extends the lifespan of the red blood cells to 42 days from 21 days or 35 days to 42 days. Normally the first bag that collects blood has CPD or CPDA1. We now transfer the red cells that you have separated out into a daughter bag that has AS additive. The half-life automatically improves to 42 days and you can store the blood and use it for up to 42 days at temperature of 1 to 6 degree centigrade. You don't want to store the blood below 1 degree. If you store it below 1 degree, it's going to hemolyze the red cells. The red blood cell membranes become unstable and are going to hemolyze and all that. So I think that's basically it. And then there are two ways of making plasma, making platelets from pooled products. It's either you separate at the buffy coat or the plasma. You can just have only if you have only plasma and red cells, you can just decant all the upper parts, the plasma and the platelets decant it and then spin the plasma very well again. And then all the things that settle at the bottom will be platelets. Then you can now decant out the plasma and pick out the platelets. So that's it. So that's basically it for now. Um Now, why is this important? Because blood bank needs to teach you how to be efficient in production and maximizing resources. One donation can help multiple patients. On one hand, the anemic patients from one donor can give red cells to one anemic patient. The same donor gives platelets to someone that has thrombocytopenia. The same donor gives plasma to someone that needs transfusion plasma that is bleeding or has clotting factor problems and all that. So that's why these things are very, very important in teaching us the importance and the use of all these things. By the way, I talk about CPD and CPDA1 as a main product you find in the mother bag, where that's separated out into the other bag for red cells that contain AS1, AS3, AS5, and AS7. In the exam, we want to ask you which of the additive solutions has no mannitol. The one that doesn't have mannitol is AS3. AS1, 5, and 7 have mannitol. What's the essence of mannitol? Mannitol is important for stabilizing red blood cells membrane and preventing hemolysis of the red blood cell membrane. Also preventing, ions or the called free scavengers from coming to destroy and puncture the red cell membranes. That's why AS, additive solutions usually contain mannitol except AS3. AS3 doesn't contain mannitol, but it contains citrate and dextrose citrate and phosphate or something like that are also important in preserving red cell membranes or thereabout. But in case they ask you, that may be a very technical question, but they can ask anything, and one has to be very prepared. Should they ask you what, and then don't forget that A stands for adenine. For all these preservatives, A adenine, and AS contains adenine, more glucose, and all that. Okay. Now, the we mentioned already that if you send blood from the blood bank to the hospital, there are little tests they have to redo. They do the ABO blood group testing, and they repeat ROH if ROH is negative. You know, if it's an RH negative something, then they have to repeat the RH testing to confirm that it's negative. Okay. Apart from that, those are the two tests they do, and they use the segments attached to the blood bag to do it. Even as blood bag has these things attached to it called segments. Okay, let's now get into the additives and see what we can do with the additives right now. So, can red blood cell anticoagulant additive solutions and why the 2,3-DPG shows up on the board exams is remember that if you look at glycolysis, by the way, our blood banks has anticoagulants and additives. The anticoagulant is the CPD and CPDA1. CPD can preserve the red cell for 21 days. CPDA1 can preserve it for 35 days. Then the additive solution, additives is another thing that's found in another blood bag. AS1, AS3, AS5, AS7. The additives can extend the lifespan to 42 days. The issue is that why you store red cells? You want to store it so you can use it when you want. But when you store red cells, more that red cells feed through glycolysis. Now, there's what we call 2,3-diphosphoglycerol. If you remember your kidney, glycolytic pathway, this 2,3-BPG, it's important for, remember, we talk about the hemoglobin oxygen dissociation curve. Hemoglobin oxygen dissociation curve. So when you have increased 2,3-BPG, it causes red cells to release oxygen to the tissues. Shifts the curve to the right. When you decrease 2,3-BPG, the curve shifts to the left, and red cells kind of to retain the oxygen and even try to drag the oxygen out of the tissues. So the oxygenated blood will have low 2,3-DPG because when they get to the lungs, they want to grab as much oxygen as possible. Whereas oxygenated blood, will have a lot of 2,3-DPG. Let's take a look at it in that direction. So when you store red blood cells, the problem is that 2,3-BPG begins to deplete. In the first 1 week of storage, 2,3-DPG would have depleted to like around 50%. But the second week of storage, 2,3-DPG would have gone to zero. So if blood has ever stored beyond 2 days to beyond 2 weeks, and you give somebody blood that has been stored beyond 2 weeks, what happens is that the person will not have 2,3-BPG. So this oxygen, this blood will hold on to oxygen and will not want to release it. But the good news is that as soon as you finish transfusing the blood, the red cells come alive again and they begin to regenerate their 2,3-DPG. The cells of the body and the red cells will begin to regenerate new 2,3-DPG. So within 24 hours, the red cells will have recovered their 2,3-DPG. 2,3-BPG or about diphosphoglycerate or biphosphoglycerate, they will recover it and now be able to function effectively and release oxygen to tissues. Um, that's basically it for 2,3-BPG. So within 1 to 2 weeks, they deplete, and then where I think that's basically it for now. So now let's go to we mentioned already the issue of mannitol and all that. Let's now go to storage, transport, and reissue. Storage, transport, and reissue, and the temperature mindset. The first thing you want to know is that red blood cells are stored in the blood bank in a refrigerator, not in freezer, at a temperature of 1 to 6 degrees centigrade. And anything above 6 degrees centigrade promotes bacterial growth. Anything below 1 degree centigrade will cause red blood cells membranes to be lysed. So you have to be between 1 to 6 degrees centigrade. However, if we send out the blood to the patient's bedside, we cannot become more lenient. We want to send out the blood. We can increase our cutoff from 6 degrees centigrade to 10 degrees centigrade. Anything above 10 degrees centigrade, it must be returned to the blood bank within 30 minutes. If somebody grabbed blood in his hand and left, that blood, if it's not used, must be returned within 30 minutes. If you return after 30 minutes, you discard the blood. That's why nurses use coolers. Why do they use coolers? You have to, now the cooler has to be monitored. The temperature must never go above 10. If you use a cooler, yes, you can now keep the blood for more than 30 minutes. Maybe they may not use the blood for 2 hours, 3 hours, 4 hours, maybe 5 hours, something like that. But at least you should never drop below, you should never go above, should never go above 10 degrees centigrade. If at any time it goes above 10 degrees centigrade and was outside during that time for more than 30 minutes, then you discard that blood. But if it was maintained within 1 to 10 degrees centigrade, you can actually give it, even allow it up to 4 hours, 6 hours. It can be more lenient and accept that, because that's almost equivalent to storing that blood in the fridge. But if they return it, you must also inspect it and make sure that it does not contain bacteria, does not contain blood clot, does not contain thrombosis, and all those things and all that. So, um, that's the thing about it. The board exam. They want to test this issue of 30 minutes. 30 minutes is if temperature was not controlled, or if you're not sure. If you don't know if temperature was controlled or not, you discard it. If it came back after 30 minutes, but if temperature was controlled, you don't discard. And there's what we call, for when blood is returned to you in blood bank, you collect it. Okay, and that means you'll be able to reissue it again. There are some conditions that must be met before the issue can take place. Number one, the blood product returned must not be spiked. It's not that somebody has spiked it, put in an infusion set, and then want to return it. No, once it's spiked, it's condemned. The temperatures must be maintained, like I say, within 1 to 10 degrees centigrade. Don't forget that platelets must never be frozen. Platelets must always be at room temperature and must never be refrigerated. When you refrigerate platelets that should have lost for last 5 to 7 days, their lifespan reduced to only 1 day because you inactivate them. And then the blood product you are returning must have segments attached to it. Segments are all those legs that are attached to the blood product that you can pull to do your testing and all that. You can put in, you can do you cannot puncture a blood bag and withdraw blood from it to do a testing. If you do that, you have converted it from a closed system to an open system, and that thing should be used within 4 hours or discarded. Once you convert blood to open system, it has to be used within 4 hours or discarded or something like that. We'll come to that. So segment must be present, and then you inspect it and all that before you receive it into the general inventory or into the general unit. Okay, so that's basically that for blood, for storage and temperature for the issue concerning the issue of reissue. So let's quickly look at liquid reduction. Let's go to the next slide. We'll soon finish. Liquid reduction, what it helps and why pre-storage is preferred. We've really dealt with this times with that number, and but for it to appear again is because we are trying to emphasize some points. Liquid reduction means when you are collecting blood from the donor, you use a filter to filter white blood cells to prevent what? Three things: febrile hemolytic transfusion reaction, CMV transmission, and HLA, human HLA alloimmunization, or antibodies against human leukocyte, which can cause platelet refractoriness and can also, affect. Those HLA antibodies can also affect. If the person wants to receive future organ donation, it may affect it and all that. Actually, that So you don't want to generate HLA immunization. You don't want that. Okay. I remember that the best kind of liquid reduction is the one that is done at the donor center. Not the one done in the hospital. In terms of QC, they'll ask you quality assurance questions in the exam. In terms of quality QA questions to QC, usually leukoreduced products must have less than 5 times 10 raised to the power 6 residual white blood cells per component. So the exam they will ask you, some people ask you what do you define as leukoreduction? You must have when you do liquid reduction, you filter out the white blood cells in the person donor. So the amount of white blood cells left in the red cell should be less than 5 times 10 to the power 6 residual white blood cells. So that's liquid reduction. The product must have less than 5 times 10 raised to the power 6. When we get into full discussions on all these things, we should be able to look at these numbers again and again and again, and to become very easy and clear to us. So liquid reduction helps to reduce CLV infection and even HCLV1 to an extent. Okay. So don't forget the 5 times 10 to the power 6, 10 to the power 6. That's a QC question and all that. Don't forget that liquid reduction is not the same thing as irradiation. Liquid reduction is for to prevent febrile non-hemolytic transfusion reactions because the white blood cells will release cytokines that have been removed, HLA immunization, and decrease CMV. Irradiation main job is to prevent transfusion-associated graft versus disease, in which by irradiating white blood cells, it inactivates the T lymphocytes. The T lymphocyte that used to go and cause, used to go and attack the host bone marrow. So transfusion-associated graft versus disease, we inactivate those T lymphocytes, and when we inactivate the T lymphocytes, the T lymphocyte will not be able to cause transfusion-associated graft versus disease. Irradiation does not prevent CMV. Irradiation only inactivates white blood cells. Even if it inactivates white blood cells, the CMV in the white blood cells will survive. Radiation does not prevent alloimmunization. Alloimmunization, even if white blood cells have been activated and dead, their antigens can still stimulate antibody response. It does not prevent HLA alloimmunization. So to prevent HLA alloimmunization, you do liquid reduction. And liquid reduction will, we remove like 99.9% of the white blood cells. And the QA will tell us that you have less than, or you have to have less than, I think is less than, not less than or equal to, less than 5 times 10 to the power 6. The exam is, some people can be so wicked. They'll be testing you under with less than or equal to, all kind of thing. So if you're less than 5 times 10 to the power 6, remember I told you that for platelet that's gotten through apheresis should be greater than or equal to 3 times 10 raised to the power 11 per of platelets per unit. But if it's pulled from 5 donors, you know, um, each whole blood donor unit should have 5.5 greater than or equal to 5.5 times 10 raised to the power 10. We can look at the issue of how we create cryoprecipitate. So we'll look at cryoprecipitate manufacture, how we manufacture cryoprecipitates, the contents of cryoprecipitates, and what the cryoprecipitate must contain. These are exam questions. The concept of cryoprecipitates. So the first thing is how to manufacture cryoprecipitates. Remember that when you get your whole blood, you separate it into 3 components, or you get plasmapheresis. You can now create new plasma. When you freeze that plasma within the first 8 hours, it becomes fresh frozen plasma, and then you can store it at less than or equal to minus 18 degrees centigrade for up to 1 year. Now, when you want to make cryoprecipitate, you go to that fridge where you stored that fresh frozen plasma, and you pull it out and you thaw it. Thaw it means that you allow it to melt. For you to make fresh frozen, I mean to make cryoprecipitate, you should thaw it at 1 to 6 degrees centigrade, not 37 degrees centigrade. If you thaw fresh frozen plasma at 37 degrees centigrade, that's thawed. We call it thawed fresh frozen plasma. Call it thawed fresh frozen plasma. But if you in the exam, there's fresh frozen plasma, there's PF24, there's thawed fresh frozen plasma, there's thawed plasma. All these 4 things, you have to know the differences between them. So when you thaw fresh frozen plasma at room temperature, 37 degree, no, at body temperature, 37 degrees centigrade, you have what we call thawed fresh frozen plasma. If you take that thawed fresh frozen plasma and go and put it back in the fridge for 5 days, you can store it up to 5 days. It's now called, you change the name from fresh frozen plasma to thawed plasma. The reason why we don't want to call it third, the reason why we have to call it third plasma is because once you thaw something, after 8 hours, some of the clotting factors begin to disappear. So if you want to keep it for 5 days, you have to call it thawed plasma. No more thawed fresh frozen plasma. If in the first few hours or thereabouts, I think we'll come to that. They can call it thawed fresh frozen plasma. But that's not what we are concerned about right now. I also just want to let you know that when you are thawing fresh frozen plasma, you actually, it depends on the temperature you are thawing it. Now, for you to make cryoprecipitate, you have to thaw fresh frozen plasma at the temperature of 1 to 6 degrees centigrade. And you thaw it slowly. And when you begin to thaw it, you see that it will begin to precipitate some slushy pellets of insoluble proteins. Those looks like snow. If you ever carry snow in your hand, the way snow is slushy, you try to eat snow, put it in your mouth, you just disappear. It just and form one ice block in your tongue or something like that. Now, that kind of slushy, snowy feeling, that slush, it will precipitate like snow. Also, that's a slushy precipitate. So, call it slushy pellets of insoluble proteins. It's going to precipitate. So as you turn the plasma, these precipitates they will go to the bottom. As they are precipitating, they'll be storing themselves in the bottom, storing at the bottom of the container, at the bottom of the container until the whole plasma melts. Just like when you carry um Coca-Cola that is blocked and you are melting it. You know, you don't use you melt this one at a cold temperature. It takes time to melt. So when it melts, finish melting, it's going to be stored at the bottom. Then when you store at the bottom of the container, plasma will be floating on top. The precipitates that are slushy like snow will be at the bottom. So what do? You decant the supernatant plasma. The plasma this plasma that are stored and released cryoprecipitates at the bottom, you kind of you discard it into a different container. That plasma is now going to be called CROP. CROP means cryoprecipitate residual plasma. That is plasma that cryoprecipitate has been taken away from it. CRP, cryoprecipitate residual plasma or something like that. So you remove the supernatant plasma. You can just leave and no, but the thing is that you still need some small amount of plasma to dissolve your cryoprecipitate. I mean, so that your cryoprecipitate can float in that plasma. So you can leave like 10 to 20 mils, you know, of the plasma so that your cryoprecipitate can float. But with experience, you don't need to be measuring anything. You just leave enough plasma to allow your cryoprecipitate to be floating around. So the usually is only about 15 to 20 mils of cryoprecipitate can form from a plasma sample. Only about 15 to 20 mils, very small. So once you got your cryoprecipitate floating in a small amount of plasma, what do? You take that small volume and that small container that has been, and then freeze it again. When you now freeze it, you now store it at minus 18 degrees centigrade for up to a year. That's what we call cryoprecipitates. It's also like frozen plasma, but this time around you precipitated it and then refroze it. That's called cryoprecipitated, you know, and it contains a lot of factors like factor 8 and all that. That's why it's called cryoprecipitated anti-hemophilic factor, you know. So how to do it efficiently. So fresh frozen plasma is stored at 1 to 2 to 6 degrees centigrade. And when it's stored there, the cryoprecipitate that is formed has to be refrozen within 1 hour of the thawing to preserve the activity. Remember that you are dealing with clotting factors that they get degraded with time. So that to be frozen within 1 hour after the thawing. And it can be stored at minus 18 degrees centigrade for up to 1 year from the original collections. The question now becomes what are the contents of cryoprecipitates? Cryoprecipitate is rich in certain cold insoluble proteins. There are some proteins that are not soluble, that they are precipitated of the solution and in cold. And number one is fibrinogen. Somebody might have acquired this fibrinogenemia or hypofibrogenemia, maybe DIC. DIC is a conjunctive coagulopathy. fibrinogen is consumed, and then the person is bleeding from all the orifices, of veins and all that. It needs fibrinogen. So cryoprecipitate contains fibrinogen, factor one. Even though right now we have what we call fibrinogen concentrate that can be used in those kind of conditions, but it's expensive, it's not always available, blood is cheaper. So fresh cryoprecipitate contains fibrinogen or factor one. And that thing it contains is von Willebrand factor. Von Willebrand factor, VWF, von Willebrand factor, people that have von Willebrand disease, also contains factor 8. Factor 8 is usually very closely associated with factor 8 is usually closely associated with von Willebrand factor. So sulfurylation plasma, so cryoprecipitate contains fibrinogen, it contains von Willebrand factor, contains factor 8, and that name for factor 8 is AHF or anti-hemophilic factor. Factor 8 used to be used to treat hemophilia E. That's why they used to call it anti-hemophilic factor because they used to treat hemophilia E individuals. Hemophilia E individuals are those that lack factor 8. Then I got the contains factor 13. Factor 13 also is found in cryoprecipitate. It precipitates out. Then finally, fibronectin. These are all the proteins that precipitate to form cryoprecipitate. Fibronectin is a protein that is involved in wound healing. It can also be present. And there are some QA standards. Usually, one cryoprecipitate can have up to 200 to 250 milligrams of fibrinogen. But in terms of quality assurance, WHO recommends that for cryoprecipitate to be standard, it must contain a lot of factor 8, a lot of fibrinogen. That fibrinogen is the main thing that that's consumed in DIC and can cause issues. So cryoprecipitates must have greater than or equal to 150 fibrinogen, 150 milligram of fibrinogen, or greater than or equal to 80 international units of factor 8. So these are very, very important values you must look at. So greater than or equal to 80 international units of factor 8, or and greater than or equal to 150 milligrams of fibrinogen. Those are the most things you must find in people that are taking that have cryo precipitate. So that's the minimum allowed. I remember that. So they'll ask you what are the 1 unit of cryo precipitate. We give you what one at minimum of 150 milligram of fibrinogen. A lot of times it's up to 250, and then getting equal to 8 units of factor 8. Now, 1 unit is very small. It's what we call adult dosing. For an adult dose means 5 packs of cryoprecipitate. So adult dose, that means if somebody really adult is bleeding and needs cryoprecipitate, you have to take out all those 5 of those units. That's what we call adult dose and all that. And then that means normally one dose of cryoprecipitate will be around 10 to 15 mils. That means an adult dose will be around 50 to 75 mils of cryoprecipitate. And the good thing is that it doesn't contain too much volume, too much fluid in it. So when you give cryoprecipitate, like I mentioned, in acquired hypofibrinogemia, fibrinogen, fibrinogenemia, like DIC, massive transfusion protocols, that this fibrinogenemia, also you can also use cryoprecipitate for people that have Willebrand disease. Although there's very small amount of Willebrand disease in small amount of Willebrand disease in not too small and cryo precipitates. So it's a second line treatment for Willebrand disease and hemophilia E. You remember that factor 8 has to be greater than equal to 8 international units. Now, factor 8 concentrates, I think, should be available by now. So I don't think you really need cryo precipitate to treat hemophilia E. But hemophilia E, sorry, but um, cryo precipitate can actually contain a lot of factor 8 that can help hemophilia E patients. Even though I think I don't really need clear perspective to teach factor 8 deficiency and all that. So factor 13 deficiency, can also be treated with clear precipitate. People that have uremic bleeding, normal platelet function and all that. So factor 13 deficiency can be treated with clear precipitates. Um, so that has answered most of our questions already. Asking an example, they may ask you which clotting factor is not found in cryoprecipitates. What the trick to that question is knowing what is found. You find fibrinogen, you find factor 8, valvular factor. You find factor A is valvular factor. You find fibrinolectin and factor 13. You find yes, fibronectin, and then fibronectin and factor 13. Either that thing, factor 7, factor 2, factor 5, all those things, factor 10, they are not found in cryoprecipitate. And they will want to test you on that. And they'll ask you when the now, final thing we'll discuss before we close off this session is the issue of I think we're supposed to look at the concept of let's see if we can quickly look at the concept of CRP, and then we'll close off from there. Like I said, we have to be very patient in blood bank, otherwise we'll, we'll just rush through everything. So this is an overview. That's why the overview is kind of huge, because you're dealing with a lot of new terminologies, a lot of new things that we have to introduce. Let's quickly look at the concept of cryoprecipitate. Um, I think what they call cryoprecipitate, thawed cryo pooled, thawed cryo plus pooled cryo storage and labeling traps and all that. So let's quickly look at that, and then we'll do CRP, and then we'll end at the level of CRP. I think if we end at level of CRP, yes, we should end at CRP. I think we should. Yes, let's do it. Let me see. I have 5 minutes. Let's see how we can cut it. Let's come to third cryo. Remember when you thought cryoprecipitate is thawed from fresh frozen plasma. Okay. Sorry, when you want sorry, no, sorry. When you make cryoprecipitates, production is using fresh frozen plasma. You thaw it at 1 to 6 degrees centigrade. Now, we're no longer dealing with the issue of producing cryoprecipitates. We have produced it. We have precipitated it. We have kept it now in the refrigerator. Somebody now needs the cryoprecipitate. What do? We have to thaw the cryoprecipitate. This is where you have to be careful. So, at what temperature do we thaw cryoprecipitate? 37 degrees centigrade in a water bath or an approved thawer. 37 degrees centigrade. We don't thaw at 1 to 6. Remember, if you thaw it at 1 to 6, it will still form a precipitate. When it's frozen, it's hard. At 1 to 6 degrees centigrade, it looks like a slush, like snow. So you don't want to do that. So you want to thaw at 37 degree water bath so that it will be completely liquid. That's room temperature. Not even room temperature. In the exam, they may say, how do you thaw cryoprecipitate? It's not room temperature. It's 37 degrees centigrade. So you thaw cryo at 37 degrees centigrade just before you issue it. And then once you thaw it, there's no reversing. You can't go back and freeze it again. No. And once you thaw it, you now leave it now to remain at room temperature and must be used within 6 hours. If it's in room temperature, 6 hours is a closed unit. Closed unit means that everything is sterile. This since the whole broad product system has not been tampered with or opened since production. That's a sterile system. A non-sterile system means for some reason somebody has opened up the bag or put a needle in or something. That's a pool, or when you put some pool system, sometimes people take a lot of plasma from different patients. Like I told you, 1 unit of cryoprecipitate is like 10 to 15 mils, but that's not an adult dose. Adult dose is like 50 to 75 mils or 45 mils or something like that. So adult dose would mean that to get an adult dose, sometimes people may have to pull different plasmas together and then make it form cryoprecipitate from it to get up to 5 pools, up to 5 units in one pool. So that's pulled when you are pulling plasma from different bags, you may be opening them and pulling out the plasma. That will call an open system. If you make cryoprecipitate from an open system, it expires within 4 hours. 4 hours. That's why if you want if you are throwing cryoprecipitate, it should be because they have ordered it and they want to use it. So that will be used within 6 hours in an open system. So in a closed system, really, that doesn't have bacterial contamination, or 4 hours in an open system. In the United Kingdom, they just have a rule of four. They don't want to say 4 and 6, open, close. No, four. After 4 hours, you discard the cryoprecipitate if it's not used. The United States will say 6 hours, for closed system, 4 hours for open system and all that. Some labs will just say 4 hours just for a general rule so that they simplify their life and don't have to be saying for open system, for closed system and all that. And remember, if the plasma if the correct possibility is pooled, oh, I'm just rounding up. Sorry, if the correct possibility is pooled from different sources, we will call it pulled from different sources. We call it pooled correct precipitate. Why? Because we want to maintain the resource factor. Resource factor can be resource negative or resource positive and all that. So you want to make sure that you want to tell the patient that this is it may be resource positive, but correct precipitate is not very significant when it comes to resource factors. It's red blood cells that you need to look at resource factors or granulocyte. But some people still worry about it. If you are worried, give the person Rogam to destroy any innervated red blood cells that must have entered the cryo um, precipitates. All that. So because of time, we're going to stop here. When we come next time, we're going to start with cryoprecipitate reduced plasma (CRP), and then hopefully that will be we completely run to the end and maybe even enter a new topic. But thank you very much for your time, and I hope you learned something.